All right, let's set the scene. You've got a patient with some known heart disease, and they need a big operation, something that's not on the heart itself, like a major vascular surgery. For years, the thinking was pretty simple. Before you put the body through all that stress, you should probably tune up the heart first, right? Fix the blockages, make sure it's ready. But what if I told you that whole idea, as logical as it sounds, might be completely wrong? Today, we're going to dig into the evidence that has totally flipped our understanding of cardiac risk around surgery. So, here's the classic question that every clinician has wrestled with. Your patient has stable coronary artery disease, they're not actively having a heart attack, their symptoms are under control, but they're scheduled for a major surgery. The big debate has always been, do we send them to the cath lab for a preemptive stent, or maybe even for bypass surgery, before that other operation? It just feels like the safe play, doesn't it? Being proactive. This was the old paradigm. But of course, good medicine means you have to test your assumptions. And that's exactly what the landmark CARP trial did. Researchers took a group of high-risk patients who all needed major vascular surgery, and they split them into two groups. Group 1 got the full tune-up. That means they got a stent or bypass before their big operation. Group 2, they skipped all that. They just got the best medical therapy we had, beta blockers, statins, the works, and went straight to their needed surgery. It was a direct head-to-head showdown between these two very different approaches. So, what happened? Well, the results were a real shocker. They followed these patients for over 2.5 years, and when they crunched the numbers, there was absolutely no difference in who lived or died. 22% mortality in the tune-up group, 23% in the other, basically a wash. And what about the main reason for doing it, preventing a heart attack right after surgery? Again, nothing. 12% versus 14%. It turns out, all that extra intervention, all that risk and cost, it just didn't help. Fixing those stable blockages beforehand didn't save lives, and it didn't stop heart attacks. Okay, so that result is a total game changer. If going in and fixing the plumbing doesn't make things safer, it forces us to ask a much bigger question. What are we missing? What's the real threat to these patients during surgery? And it turns out the answer has a lot less to do with the anatomy of the pipes and everything to do with the physiology of the pump and the pressure inside them. Just look at this number for a second. 65.3%. What is that? Well, according to the huge POISE trial, that's the percentage of heart attacks around the time of surgery that are totally silent, as in the patient feels nothing. No chest pain, no shortness of breath, zero classic symptoms. The damage is just happening quietly in the background. And that's a huge deal, because it means the danger we're trying to prevent is often invisible unless you're specifically looking for it. So, this silent threat now has a name, MINS. It stands for myocardial injury after non-cardiac surgery. And we define it by a rise in troponins. That protein that leaks out when heart muscle gets damaged from a lack of oxygen? But here is the critical part. MINS is a massive, independent predictor of death within 30 days. And it doesn't matter if the patient felt the thing or not. This silent damage is incredibly dangerous. So what's causing this silent damage? Well, a huge culprit is low blood pressure. And this data shows it perfectly. It's what we call a dose-response relationship. Look at the risk of heart injury based on how long a patient's mean arterial pressure, or MAP, dipped below 55. Even just 1 to 5 minutes in that zone, and your odds of injury go up. But if you spend more than 20 minutes down there, the odds almost double. It's a ticking clock. The longer the blood pressure stays low, the higher the risk of hurting the heart. And when that low blood pressure gets really severe, we're not just talking about injury anymore. We're talking about death. This data is pretty stark. If you have a severe drop in blood pressure that lasts for 5 minutes or more, the risk of dying within 30 days skyrockets. A systolic pressure below 70, your odds of death nearly triple. A diastolic below 30, it more than triples. This is the danger zone. It makes you realize that managing blood pressure isn't just some small detail, it's a primary goal. Okay, so that brings us to a super practical question that comes up all the time. Millions of patients are on ACE inhibitors or ARBs. And these drugs are great for their long-term health, but they can also make it harder for the body to keep the blood pressure up during the stress of surgery and anesthesia. So the big debate is, do they take that pill on the morning of surgery or do they hold it?
Well, luckily, the huge VISION study gives us a really clear signal. They looked at patients who continued their ACE inhibitors or ARBs versus those who held them for a day. And the results speak for themselves. Holding the medication was linked to an 18% lower risk of the really bad stuff, death, heart injury, or stroke. And if you ask why, it makes perfect sense. Holding the meds was also linked to a 20% lower risk of that dangerous intraoperative hypotension we were just talking about.
And now for the final piece of the puzzle. This is the part that really ties it all together and cements this new way of thinking. A sub-study of Vision actually did CT scans of patients' coronary arteries before surgery, so they knew exactly what the anatomy looked like. And the findings were just incredible. They confirmed low blood pressure is tied to bad outcomes, sure, but here's the kicker. This connection was there even in patients who had completely normal, clean arteries. The severity of your blockages didn't really change the risk from hypotension. It's a universal danger. It's all about physiology, not anatomy. So, after all this evidence, what's the bottom line for keeping our patients safe? Well, it means we need to throw out the old playbook. It's time for a new one, a playbook that shifts our focus away from fixing anatomy before surgery and puts it squarely on managing physiology during and after. So, what does this new playbook look like on the ground? It boils down to 4 key actions. First, avoid routine tune-ups for stable coronary disease. CARP showed us it doesn't work. Second, maintain blood pressure. Keep that mean arterial pressure above 65. Stay out of that danger zone. Third, consider holding those ACE inhibitors and ARBs for 24 hours before surgery. And fourth, and this is a big one, monitor for the silent enemy. Check those post-op troponins to catch MINS before it's too late. You know what's amazing is that the researchers who ran the original CARP trial kind of saw this coming. Right in their 2004 paper, they wrote this. They actually suggested that maybe the reason the no tune-up group did just fine wasn't the lack of intervention itself, but the fact that they were being watched so closely. It was the intense management, the careful monitoring. They hit the nail on the head. Vigilance is what saves lives. And that really leaves us with a final thought to chew on. We always think of the surgery itself as the main event, right? The most dangerous part. But maybe the real high-wire act, the most critical part for the heart, isn't what the surgeon is doing. Maybe it's the quiet, minute-by-minute battle to manage blood pressure and oxygen supply in the hours that follow. It's mastering the silent physiology of recovery.